All right. Hi, everyone. Good afternoon. Thanks for joining us I think this is our first ROVER session for the academic year. It's going to be on lung malignancies, and I'm very excited to introduce our three esteemed speakers. So if you guys want to introduce yourselves, maybe starting with Dr. Rosenburg.
Sure. Well, again, thanks so much for having me, Ria, and the whole ROVER team. My name is Stephen Rosenburg. I'm an associate member at Moffitt Cancer Center. I focus on thoracic malignancies.
Hi, everyone. My name is Amini. Thank you, Rover, and everyone for having me. I'm a thoracic radiation oncologist at City of Hope.
I am Ken Rosenzweig. I'm a chair at Mount Sinai and specialize in thoracic malignancies.
Thank you so much. We're very excited to have you. And for the listeners, each of the attendings are going to be presenting cases. So we have early stage non-small cell, a locally advanced non-small cell, and then small cell lung cancer cases. So hopefully this can be a good review for everyone. And my name's Ria. I'm a PGY5 resident at University of Pittsburgh, UPMC. So starting with Dr. Rosenburg, a case on early stage non-small cell. And I'll be advancing the slides, Dr. Rosenburg. So if you need me to slow down or speed up, just let me know.
Sounds good. Well, thanks again so much for having me. The obligatory Twitter X handle is also on there. If you want to connect with me on there, feel free to do that. I'm also at our family shore house while I'm doing this. If you see a child run in the background or you happen to hear something else happen while we're on Zoom, my apologies, and we'll roll with it. So with that, let's go ahead and get started talking about early stage non-small cell lung cancer. So of course, we'll start with a case. Our first case is a 77-year-old gentleman who presented to you with a nodular mass posterior to the trachea and adjacent to the esophagus. The CT scan is sort of shown on the right of your screen with the trachea outline, the esophagus, and this tumor-looking mass posterior and adjacent to those structures. The patient underwent an EBUS that was consistent with a squamous cell carcinoma. Of course, there's very important information you want to gather from the EBUS. We can go through what that's going to be and what the next steps are going to be in workup for this patient. So the most important thing we sort of see here on the EBUS is there's no signs of endobronchial invasion, no signs of invading the airways, and the PET-CT shows no signs of local regional spread. So we have a 1.7 centimeter squamous cell carcinoma directly adjacent to these critical structures with no signs of distant spread. Next slide. So we have sort of two main poll questions to talk about here. Is that this patient was not interested in a surgical approach and not felt to be easily resectable. What dose and fractionation would you offer for a patient like that? I don't know if we'll get to see the results right now or if they come a little bit later or we do the next poll question next. So in terms of our poll results, I don't know if everybody can see this, but about 44% of patients, 44% of everybody would do 50 gray and 5 to 10 fractions. Another quarter will do 60 gray and 8 fractions. Another 31% would do about 60 gray and 15 fractions. No long course fractionation as we sort of see here. So interesting, a wide range of answers, which is why I think that's such a good, question. And then, of course, how do you define this sort of lesion? Peripheral, central, ultracentral? I'll look on the scan. Okay. So about 73% describe this as ultra central, and about 13% called this central. A few people called this peripheral as well when it comes to that. Okay. Let's move on to the next slide. So I think it's important as we think about early stage non-small cell lung cancer to think about location and the data that sort of evolved over the last 20 years and how we define central lesions and ultracentral lesions. And so if you go back to the Timmerman definition that I think we're all aware of is, that 2 centimeters around the trachea and main stem bronchus was sort of our proximal bronchial tree, and that 2 centimeter was sort of the no-fly zone. And that was our first definition of central lesions. RTOG 0813 sort of, slightly altered this definition where it was within or touching a high-risk zone, which was, again, 2 centimeters around the proximal bronchial tree or immediately adjacent to the mediastinal or pericardial pleura. And that was how RTOG 0813 defined a central lesion. These are central tumors that I think are pretty well defined by most folks. Next slide. Ultracentral tumors are a little bit of a tougher nut. And the whole idea here is that there hasn't been a lot of consistent definitions of what actually makes something ultracentral. Some of our colleagues, for example, on the far left of your screen, have described PTV overlap of the trachea or mainstem bronchi as ultracentral. Some have described it less than 1 centimeter from the critical proximal bronchial tree, and that's the Hylas definition. At Moffitt Cancer Center, I in general have sort of taken on the Hylas definition, which sort of has tumor less than 1 centimeter, either from the trachea or mainstem bronchi, which would be a Hylas A, or less than 1 centimeter from other major critical structures such as lobar bronchus, Hylas B. Hylas A are felt to be a little bit more of a high-risk tumor, and this is sort of what falls in what I call a ultracentral tumor based on the Hylas definition. And so because I talk about the Hylas definition, it's important to talk about the Nordic Hylas trial and how this sort of impacts our thinking about ultracentral. So next slide. So for those who aren't aware, the Nordic Hylas phase 2 study was looking at SBRT to these ultracentral tumors, 7 gray times 8, the Netherlands fractionation, or a close to Netherlands fractionation, which was again used to be 7.5 times 8, for 65 patients to find less than 1 centimeter from the proximal bronchial tree. No endobronchial tumors were allowed in that study. And again, there were sort of 2 cohorts here. Cohort A was that group A, less than 1 centimeter from the main bronchi and trachea. Cohort B was all other patients. What you can see on the top of your screen, up in the back real quick, top of your screen, these are different stars showing whether somebody had a local failure, whether they had progression, also whether they had a grade 5 toxicity or not, which was ended up being a red star. And what you can see in that group A is there's quite a number of red stars. And now we can go to the next slide. And so with this 7 gray times 8 approach for these ultracentral tumors, 34% of patients developed a grade 3 to 5 toxicity, with 15% of patients actually with a grade 5 toxicity, with the majority of happening in group A. And I really want to emphasize here that, as you can sort of see on, most of these were a bleeding, a hemoptysis-related event. And we can see in sort of panel A there is that a lot of these events actually didn't happen right away. They happened between year 1 and year 2. So it's a little bit of a later toxicity. It's not something we see, say, 3 months right after treatment. You can, but it's something that we usually see a little bit later on. And again, in panel B, you see that it's the group A patients that next to the trachea or mainstem bronchi that had the highest risk of toxicity. And the distance between the tumor and the proximal bronchial tree really also predicted for a grade 5 bleeding event. Next slide. So this is sort of the summary part of Nordic Hylas that had 65 patients, 7 grade times 8 fractions, but there was a lot of problems with this study. The first thing is that they allowed these tumors to get very hot, up to 150% hot, prescribing to the 67% isodose line. They contoured a lot of the airway lumens, but did not include walls or critical structures. The follow-up was about 24 months. And again, grade 3 to 5 toxicity was about 34%. Next. But just in 2024, there's been 2 other critical studies that have come out looking at how to treat these ultracentral tumors with either SBRT or hypofractionation. So the first one is the Sunset trial, which had 30 patients. Again, a slightly different definition of ultracentral, with ultracentral defined as PTB touches or overlaps the central bronchial tree, the esophagus, pulmonary vein, or artery. They did, again, the Netherlands fractionation, 7.5 times 8. They only allowed tumors to get about 120% hot. Their median follow-up was 37 months, and their grade 3 to 5 toxicity was only 6.7%. So much improved compared to Nordic Hylas. So we're like, well, maybe that was the one-off major problem at Nordic Hylas. But of course, this is sort of an evolving issue, and Lung Tech phase 2 also just came out about maybe 2 months ago with 31 patients, both central and ultracentral, on trial. Again, 7.5 grade times 8 fractions, up to 130% hot. Median follow-up was 3.6 years. Grade 3 to 5 toxicity was 19.4%. So it actually, they thought the toxicity in lung tech and Nordic Hylos were more similar to each other, and Sunset was a little bit sort of the outlier. So what's the right thing here? We're really not sure, but this is really an evolving area. And I wanted to summarize this on one slide so people could sort of see how the landscape has evolved pretty recently. Next slide. So why does toxicity happen? And I think this is something that, especially I try to go through with my trainees, is that a lot of the treatment planning approach we use, appears to assume that intrafraction and interfraction motion does not lead to significant alterations in the dose delivery to the targets and nearby critical organs. But that's just not the case. And I think a lot of times, at least what I try to tell the new PGY2 residents, is that we spend all this time trying to make a DVH perfect. But what you actually see on the DVH isn't actually what you deliver on a day-to-day basis. So there's what we think we deliver. This is what we actually deliver. I think this is really exemplified by the figure on the right of your screen. This is a study by Lauren Hankey when she was at WashU for actually delivering adaptive radiotherapy for ultracentral lung tumors. And all they did was they took the radiation plan that they originally had for an ultracentral lung tumor and applied it to the anatomy of the day. And how often were they violating critical organs at risk? So those red dots on the right, you can see, are basically violations either of the esophagus, the trachea, the heart, of just taking the original plan and applying it to the anatomy of the day. And it really shows you that there's slight variations in the tumor, in the anatomy, really can lead to significant changes in the dose distribution, especially when you're close to these critical OARs. And I trained at University of Wisconsin, and one of my physics mentors there, John Bayouth, used to say there's lies, and just symmetry. And that's a little bit how I think about that going forward. Next slide. So what's one of the ways around this? One of the ways we've gotten around this is using adaptive radiotherapy. And what's, just to make sure everybody's aware, is what is adaptive radiotherapy? It's changes in the radiation plan to account for physical or functional changes of a person's tumor or anatomy each and every day. And again, this is a similar figure from Dr. Hankey's phase 1, using, actually, this is MRI-guided adaptive radiotherapy, showing that, we took the original radiation plan and put it on the anatomy of the day. On the right of your screen on the bottom shows where the tracheal DVH would have been. And then when they were able to adapt based on the anatomy of the day, there was a significant decrease in the max dose to the trachea in this scenario. So by doing some adaptive radiotherapy, we're able to better personalize radiation delivery, but also help be a little bit safer for these patients. Next slide. So what's the right answer for these ultracentral lung tumors? Now, we move forward, is that unclear. I think we've incorporated adaptive radiotherapy for this high-risk population at Moffitt with the goal of lowering toxicity but maintaining tumor control. We're not the only ones that do this. Our colleagues in Amsterdam, Dr. Suresh Anand, who I've worked with quite a bit, who also works in the adaptive radiotherapy realm, has also really looked at this for treating these high-risk lung tumors. And at Moffitt, our team has also really looked at this as well. Next slide. So this is our experience using really MRI-guided adaptive radiotherapy for 47 patients. These are all patients with had central tumors by NRG criteria, and the majority of ultracentral by Nordic Hylos criteria. We traditionally usually did 60 gray and 8 fractions with a follow-up of about 23 months. Across all patients, the 1-year local control was 87%, overall survival 82%. Half these patients we were treating metastatic lesions. And in our series with 2 years of follow-up, 2 grade 3 toxicities, no grade 4 or 5 toxicity was seen. And it's important that you have enough follow-up, because I mentioned most of the toxicity can really start to occur between the 1st and 2nd year. Next slide. So I think sometimes when I give this talk, I get questions about, like, why do we need to adapt off the esophagus or proximal, airways and ultracentral tumors? And this just sort of shows one example of one of my patients. On the left of your screen is the contours. This is again on an MRI Linac, so you're looking at a trophy sequence, and the GTV is outlined there, as well as the trachea and the esophagus. When you're just basically aligning to the tumor on the right of your screen for fraction 2, there's been a slight slip in the airway and the esophagus relative to the target, just based on slight changes in anatomy. And that esophagus particularly can slide back and forth a number of millimeters. And when you're treating a more peripheral lesion, this makes no difference whatsoever. But if you're delivering high dose, either SBRT or hypofractionated radiotherapy, you could be overdosing these organs, critical OARs, very easily if you're not tracking what you're doing. But here's one example before I've adjusted any of the contours or done any sort of other adaptation. Next slide. So we've looked at this a little bit to say, if you do this, adaptive process over, like, say, 8 fractions or 15 fractions, what's the cumulative effect, to the proximal bronchial tree? This is through a rigid dose accumulation that we did at Moffitt, and saying, like, are we really decreasing when you really look at what we're delivering every day by adapting, when we sort of rigidly copy our dose and sort of try to merge where the dose is going as closely to the voxel as we can? Are we really decreasing dose to critical OARs? Next slide. And we are absolutely finding we are. And so there's 2 different dose washes here. That's a tumor in the hilar region that's sort of surrounded by airways. And on the far right is showing the hot dose. And the hot dose here is spread much more throughout the tumor and getting closer to those the proximal bronchial tree, versus in the center panel, panel B, you can see that hot is sort of confined more to the center of the tumor, which is sort of those darker colors. So not near those the thin-walled proximal bronchial trees you can sort of see here. Next slide. So back to the case presentation. This is actually, we did treat this patient on the MRI LINAC. Here's the trophy sequence showing the tumor and the nearby critical organs. We prescribed, again, 60 gray in 8 fractions. We used a PTV margin with 3 millimeters. And again, with a lot of these newer technologies like the MRI, certain MRI LINACs, we're gating and tracking, so we're not needing to do any ITV-based approach. We use a 3 millimeter sort of region of interest to trigger treatment. And we ended up adapting 7 of the 8 fractions, most often to esophageal dose for this patient. Next slide. Here's some follow-up for this patient. He had some minimal odynophagia helped by a PPI after treatment. He did have a past medical history of GERD as well. Otherwise, still doing well. Significant tumor regression there. No other toxicity was noted for this patient. Next slide. So in summary, ultracentral lung tumors have a very narrow therapeutic window for SBRT. Next. The Nordic Hylas trial highlights the need for both advanced radiotherapy techniques, small margins to safely treat, and also being careful about what we're contouring and how we're delivering dose. Next. However, there's a lot of variability amongst trials for these ultracentral lung tumors, making it very difficult to interpret what's the right fractionation or what's the right thing to do, as we sort of highlighted between Nordic Hylas, between Sunset and Lung Tech. Next. The fractionation choice here in that context may depend on the technology available and honestly your institutional's experience there. And we saw in the poll, there was a wide range of fractionations that people chose in this scenario. Next bullet. The advantages of MRI-guided or adaptive radiotherapy here are small margins, real-time gating and tracking, and on-table planges to account for changes in daily anatomy. And I think one of my big takeaways for anyone who's sort of early in their training is that what we think we deliver versus what we actually deliver on a day-to-day basis are very different. And so we're treating a patient, we're not treating a DVH, and it's a really important part of how we think about something like this. So I believe that's all I had. And of course, connect with me via email, Twitter, anything I can be helpful with, please reach out.
Thank you so much, Dr. Rosenberg. That was a really excellent presentation, and it's cool to see some images from MR-guided adaptive. If there are any questions from the audience, we have a couple of minutes, so feel free, participants, to just type them in the chat. It looks like we have one question already. Can you further describe the motion management used with adaptive MR? Will triggered imaging reveal if further motion has happened during the long adaptive process?
Yeah, so there's 2 main MRI LINACs out there. There's the Elekta Unity and the Meridian system, and both of them have different. Elekta Unity has what's called CMM, the Comprehensive Motion Management. Meridian also has a tracking algorithm, so you are literally tracking the tumor in real time. While in the Meridian, you're doing anywhere from 4 to 8, basically images per second, and so you're basically setting a boundary. As you're setting a boundary, the tumor comes in and out of that area. And basically the radiation turns, with about 0.2 second delay, turns on and off as long as 90, you set a sort of threshold, 99% tumor being in this boundary that you set, which is usually, equal to your PTV margin there. And so the treatment's longer because, of course, as the tumor moves and you're breathing, there is a duty cycle that goes along with that, the beam turning on and off. But, say for the tumor stops tracking for some reason, there's been a shift. Sometimes if a patient literally slightly shifts or turns or moves while they're in the bore, the tracking algorithm stops picking up the tumor. You can rescan and you found that the patient has moved. While we're delivering, we're usually not looking at any changes in anatomy unless the tracking algorithm has changed. But usually every time they come in, right, we're getting a brand new MR that day, just like we're getting a cone beam CT. We're redrawing the anatomy of the day, taking that radiation plan, predicting it on the anatomy of the day, adapting the plan as we need to, then triggering treatment. For an ultracentral lung, that whole process probably takes me nowadays with optimization 30 to 35 minutes.
That's really not bad. I was just going to ask how long the whole process takes.
It really depends how good of a breather they are too. I will find for our lung patients that I will often put them on 2 liters of supplemental oxygen, and a lot of times that will also, whether placebo or not, sometimes help them a little bit of the breathing cycle there. And no, we've really gotten it down. We have also a parallel workflow because you very much are doing some things with physics and your therapist, and so we're all sort of working in parallel to each other. And as we do that, things go pretty quick. When I started doing MRI guided radiotherapy back in 2014, I think an average treatment used to take us an hour and a half, I would say. But it's come a long way in terms of its speed.
Oh, wow. And then I guess we'll have time for one more question before we move on. But there's a comment that says, thanks for the insightful talk, Dr. Rosenburg. Just curious, have you and your institution adapted the 60 gray and 8 fractions for ultracentral tumors based on the Sunset trial or not quite yet because of the lung tech results?
We've in general, based on the, going back quite almost over a decade, the Hasbeek data, I've sort of always done 60 gray and 8 for these in general. And then, I sort of continue with that with the MRI Linac. If they're really high risk, I will go to 60 and 15. There's something that I'm really concerned about, not meeting constraints. But in general, in our paper that we published, I think now a year and a half ago, the majority of our tumors went to 60 gray and 8, but we did have some of the MD Anderson 10 fraction regimen and some of the 15 fraction regimen. Of course, we're always trying to keep that BED over the magical 100. But I think that especially with adaptive therapy, I'm very comfortable with the 60 and 8 for the vast majority. And that's basically what we've been doing for these tumors since we started the program here in about 2019.
Got it. That's very helpful. Well, thank you so much again. Again, great presentation. And then we'll move on now to our case of locally advanced non-small cell lung cancer led by Dr. Amini.
Well, great. Well, great talk. I learned a lot just listening. So I get the fun stage 3. I mean, they're all fun, but I think locally advanced is a really complicated section. And I kind of went the easy route and picked an area where I think, given this year's data, I thought it's just relevant for this group. But there's a lot of different cool cases I could have picked. And maybe next time I'll make something much more complicated. But this is a patient who is a 52-year-old male, actually treated 3 years ago, non-smoker, presented with a worsening cough, had an outside chest x-ray from his PCP, and it showed this non-specific opacity in the right lung, and then was referred to pulmonology. And for further workup, they got a CT chest, and it identified a mass in the right lung with some enlarging, sorry, it should have been right, hilar and suprahilar nodes. And then a PET scan was done, and it confirmed activity in the primary, not so much in the hilum, which I'll show you, but in also a right level 7 node. So MRI brain was also done and was negative. We can go to the next slide. So this is where the pulmonologist went in to do biopsies, came back as adenocarcinoma. And part of the teaching here, and I think most of the residents know, but for stage 3, we always do mediastinal staging. PET scans are very helpful, but the sensitivity and specificity are not as good as an EBUS. So these patients that aren't going to be getting surgery should get some form of mediastinal staging. And here we do EBUS, and I think most of the places do it just because it's less invasive than a mediastinoscopy. So very important because it helps target or delineate our volumes. So 11R was positive, 4R, 4L was also positive. So we're dealing with a contralateral hilar node as well. And molecular testing was done. The patient was actually EGFR exon 19 positive and PD-L1 of 40%. So came to me and our medical oncologist, or referred to me by our medical oncologist, and we can go to the next slide. And Multi-station N2, we presented this patient at a multidisciplinary tumor board, and our surgeons kind of looked at it, and given that it was multi-station, felt with a contralateral hilar node as well, felt that surgery was not an indication, thank God, and that we can have another case of where we're getting these borderline resectables that get, could, if this was done maybe in the last year, they might have pushed for surgery. But again, I won't get off topic on that. But again, this is a pretty clear-cut chemoradiation. You have a small primary that should respond to chemoradiation. You have multi-station N2, multi-station mediastinal disease, hilar disease, should get radiation. So I planned IMRT plan here with to 60 gray and 30 fractions. These are our dose constraints. So we met most of the constraints. The esophagus was a bit high because as we covered some of the lymph nodes, it increased the dose of the esophagus. So we can go to the next slide because I think that's my poll question that will lead to the discussion. But this patient, this was around the time, this was after the time Pacific was published. So we did, and prior to Pacific, it was always doing a scan about 3 months after, but, we did a scan 2 weeks after to look for a response, and there was a partial response. And then the patient comes to you as the radiation oncologist and says, what would you do next? So I'm curious what the audience would do in that situation. I guess I can answer it too. So it's interesting. So good. I actually like this because now it makes it for a good discussion. So I think most people went with Durva. Some people went with Tagrisso, observation, and I appreciate the honesty of the I don't knows. And nobody went with chemotherapy, which is great. So we can go through this. Things have changed a lot this last year and will continue to change, I think, for this field. But what I'll kind of run through is the different studies up to the Laura trial that was just recently published. So the Pacific trial, I'll spend a little bit of time just because we may have some newer residents as well. So to give a little bit of a backstory, I've always liked lung cancer and thought it was a fascinating field, but for most lung cancer, it wasn't too long ago that we didn't really have a lot of positive trials. When I was a medical student, when the infamous RTOG 0617 trial, which looked to dose escalate the radiation, failed, had a lower survival rate. And I remember the astroplenary session when it was dark and a lot of murmuring and kind of concerns because higher doses of radiation should matter. And we learned a lot of great things from that, including to be more cognizant of our heart and lung constraints using IMRT. But we didn't really have a positive trial until the Pacific trial came about for locally advanced lung cancer. So this trial incorporated an anti-PD-L1 that many people know already called durvalumab. And the question was whether adding this after chemoradiation would improve progression-free survival and overall survival. And there was a number of other endpoints as well. So they enrolled stage 3 lung cancer patients, unresectable, and they were randomized after a nice range of chemotherapy options that are standard. Concurrent radiation could be 54 to 66 gray. And they were randomized to durvalumab at that point, it was every 2 weeks, the way the trial was designed for 1 year versus a placebo. And we can go to the next slide. So the PFS were the first to be presented. And again, I think many people know this already, but at that point, it was a clear-cut winner that durvalumab had a significant improvement in PFS compared to placebo. The overall survival analysis subsequently came, which is the next slide, that showed a significant benefit in overall survival. They reported initially the 2-year overall survival rates, and then I'll show you the 5-year overall survival rates. But of note and of importance, and we can argue whether this is what we see in clinical practice, the rates of pneumonitis were not significantly different between the two groups. Especially grade 3 higher pneumonitis rates. And so this was felt to be safe. and basically standard of care for our locally advanced patients. So we can go to the next slide. The 5-year overall survival rates were published. Good numbers to remember. We like to ask our residents here all the time what 5-year overall survival rates are for our stage 3. And why this is kind of important too is that, stage 3 survival, and this is a little bit of history, and I'll date myself a little bit, but it wasn't too long ago before this that overall survival for stage 3 was 15-20%. So to get numbers like 42-43% is pretty exciting for us as a field and for our patients. Now, a number of subset analyses were done, post hoc analyses, and you can argue whether to take anything from it, but that's what I have highlighted below. These were unplanned, small numbers, but they did look at EGFR and ALK mutations. They looked at PD-L1 status. A lot of patients didn't have EGFR testing. So, but if you look, you can see that for the EGFR negative, there was a benefit for durva. For the positive ones, there was this question. Now, again, very small numbers, large confidence interval, I wouldn't make much of this. And then for PD-L1, main ones that I think will probably need more fancy, smart people to figure it out is probably durva may not be enough for our PD-L1 negative, and maybe we have to come up with some new combinations. But generally beneficial for our PD-L1 positive patients. So we can go to the next slide. So this is kind of where we've struggled actually as an institution. So before the LAURA trial was open and before it was reported, and I'll get to that, we kind of struggled because in the back of our medical oncologist minds was, hey, if durva works for these patients, should we be thinking, an ALK inhibitor for our ALK positive patients? Should we be thinking of, Tagrisso for our EGFR positive patients? We went with what I think the majority of the group said. So when Pacific came out for our EGFR patients, we initially started with durva. But then what we found in a few number of our patients is that the patients did progress. And when they were switched to Tagrisso, the rates of pneumonitis just skyrocketed. So patients had to then stop and go on chemotherapy and steroids. And so there was an N of not one, but a handful of patients. And so we started to question it a little bit here. So we can go to the next slide. So our colleagues here, combined with a few other institutions in California, including UC Davis, Stanford, reported out our small number of patients. So a small study here of 37 patients looking at EGFR positive patients undergoing chemoradiation. And the question was, and again, this was not on trial, and this was just people doing it because they just clinically felt maybe we shouldn't be doing durva, but Tagrisso, and again, not standard of care there. And I don't know how MedOncs got, actually, I know how MedOncs got approval for it. They kind of called it as a node positive, making it sound metastatic, and we're able to get it approved. But again, not a standard of care at that point. And what we showed in this very small number of patients is that this PFS seemed to be best in patients getting chemoradiation and an EGFR TKI compared to those getting durva or nothing. And what's interesting here is that the chemoradiation alone group did about the same as the chemoradiation and durva. So it sort of suggested that maybe for our EGFR positive patients, maintenance durvalumab didn't do much of anything. Subsequently, we were part of a bigger group, and we can go to the next slide, of many institutions. And for the residents out there, I think these studies are really impactful. There's a number of them out there that retrospective studies with multi-institutions combining. It's a lot of work. But it kind of answers some nice questions that until we get a prospective trial to answer it kind of can potentially guide us. And so this was a similar study asking the question, what should we be doing after chemoradiation for our EGFR positive patients? And again, same kind of mindset before the LAURA trial, which I'll talk about. People were kind of mixing, so I'll do durva, follow the Pacific trial. They had EGFR positive patients. No, I should do osimertinib. It makes more sense. And so what this study again kind of confirmed on a larger scale was that PFS seemed to be better for the patients getting chemoradiation followed by osimertinib compared, and again, kind of similar curves, the maintenance durvalumab didn't seem to make much of a difference. Now, one of the other things that kind of confirmed our what we were seeing in clinical practice is that the rates of pneumonitis were actually happening for the durva patients transitioning right into Tagrisso. So when patients were progressing during that year of durva, switched to Tagrisso right away. Within that 90-day window, a lot of them got pneumonitis. And so one of the study suggested is that for those patients, if patients are progressing on durvalumab, to try to wait 90 days before you switch to Tagrisso. So again, very challenging to do that because patients are sometimes symptomatic with metastatic disease. Sometimes our medical oncologists here will start with chemo while they let the half-life of durva get out of their system. So we can go to the last few slides. So that kind of, in all this that was going on, the LAURA trial was designed and opened, a really nice study that this past year reported out, which is why I wanted to present this as a case. So again, our locally advanced patients, stage 3A, B, C, EGFR mutated, getting chemoradiation or sequential chemoradiation, with the big question of randomizing afterwards to placebo versus Tagrisso. They would basically get that Tagrisso really lifelong unless there was progression or they couldn't handle due to side effects. And they were followed, and then primary endpoint was PFS. And recently, this last year, was presented and published. So in the New England Journal of Medicine, they reported out their PFS and OS rates, and I think I'm sure they'll have more updates on survival, but already, to just cut to the chase, PFS was significantly improved for patients getting Tagrisso compared to placebo. So that's kind of impacted our practice, and I think it's changing our whole practice. So for that patient, and we can go back to the case on the next slide. Oh, sorry, I had one more slide, a couple more slides. This is just their PFS based on breakdown of ethnicities. So overall, osimertinib helped really with everybody. So whether they were getting concurrent or non-concurrent at any stage, exon 19 or L858R, all benefited from the Tagrisso. The next slide is the toxicity. I know this is small. There is always this concern that, Tagrisso in the presence of prior radiation can increase pneumonitis rates, and it did. Now, grade 3 or higher was generally low for both, but especially for the radiation group, there were only a couple radiation pneumonitis patients. But I know it's small, you can see there is a higher rate of grade 1 and 2 pneumonitis in the in the patients getting Tagrisso versus placebo. So there's a little bit of caution there, but overall, not too many major differences. Also, the expected side effects from Tagrisso that, rashes, things like that we see already. So it's not a benign drug, but it's, generally well tolerated. So our patient back then actually went on Tagrisso, and I just checked actually, our chart has been on it for 3 years with no evidence of disease, and is recommended to continue it on lifelong for that patient. So that's the case I had. We're kind of cutting it close on time, so I'll open it up to any questions. That's my Twitter handle too. It's the obligatory Twitter handle, but any questions? So I guess to get to the point, I think now I would argue for Tagrisso. I don't think it's yet FDA approved, but it should be in the next, I imagine in the next few months, but sorry, questions?
Thank you so much, Dr. Amini. That was, again, a really excellent presentation. Learned a lot. We are a little short on time, but maybe if there's any questions from the audience, if you want to type them in, or if not, we can also save them for the end.
You can always email or text me too.
Okay. Yeah, thank you so much. Looks like there were absolutely no questions. So maybe we can move on then to our final presentation by Dr. Rosenzweig on limited stage small cell.
And muted without you having to tell me. Yeah, thank you very much for having me here, and thank you, Stephen and Aryeh, for those amazing talks. So hopefully I can do as well here. So the topic is limited stage small cell lung cancer. So we can go to the next slide. So this is an interesting disease because we usually think of solid tumors, so not hematologic malignancies, but with surgery or radiation being the definitive treatment. But for small cell, you can make a very good argument that chemotherapy is the definitive treatment, which is really pretty rare for a solid tumor. Back in the really old days, the treatment was cisplatin etoposide in the 80s. Whoops, that's still the chemotherapy of choice. So not a ton has changed with regard to the chemotherapy in terms of what's used in the patients, but immunotherapy is going to be incorporated pretty soon. We'll go over that as well. So if chemo is the definitive treatment here, so radiation's kind of an adjuvant treatment in small cell. Surgery is not typically used, and not because surgery doesn't work. Surgery is an excellent treatment, but these diseases usually present pretty centrally, not really going to be amenable to surgical resection, but it is useful in early stage disease, although oftentimes it's done without knowing the pathology. If we go on to the next slide, I'll present the case. This is a 71-year-old woman with a smoking history who had a productive cough. And you can see the CAT scan and the corresponding PET scan. And that's a fused image on the bottom there. So she had a large left lower lobe tumor and pretty significant left hilar and mediastinal lymphadenopathy. Very hot on the PET scan, and a bronchoscopic biopsy revealed a small cell lung cancer. A brain MR was negative, and she had a good performance status. Go on to the next slide. Question is, how would you treat someone like this? So, some of the options would, I think everyone would say concurrent chemotherapy, but there's really some question on the technique and the dose. So the standard, which might be more observed in the breach than in compliance, would be doing 45 gray BID. There's been some recent data that higher doses with the BID regimen might be helpful. But I think a lot of people, a lot of centers are doing daily treatment to doses around the 66 gray range. I actually treated her with a BID, and we do this here. We have a patient on treatment right now with a BID regimen. So there are some advantages to BID. I know it's, with 6 hours apart, it's kind of inconvenient for machines and for the patients, but for some patients, it's actually preferable depending on their location to the clinic. Medical oncologists actually like it because it only overlaps, at least the medical oncologists I've worked with, it only overlaps one cycle of chemo, so they don't have to really worry about getting their chemo in and overlapping without radiation. A lot of times patients will need a 1-week break before the next cycle of chemo, but that's not that big of a deal. And the dosimetry is easier. 45 gray is a lot easier to get in there than 66 gray. So you're going to get some favorable dosimetry as well. So this patient started carbo etoposide and we started the radiation with cycle 2. So we'll go to the next slide. This is the OG of lung cancer, small cell lung cancer, thoracic radiation. So this was a randomized trial by Drew Teresi that was published in the New England Journal. And it's always very interesting. That's strictly a radiobiology question, whether 45 gray in a once daily or twice daily regimen was better. And you can see at 5 years, the survival was significantly better, though the esophagitis increased with is not surprising. And local control improved, though non-significantly. When I'm going to talk about the guidelines that were published a few years ago, and when we got comments on the Astro guidelines, some people did point out that this trial is technically negative because the 2-year survival was the endpoint, but it's generally considered a positive trial. But people who say that are technically correct. So if you go to the next slide, there's been some work on whether higher doses of twice daily thoracic radiation might be helpful. So there's a trial from Norway, a phase 2 randomized controlled trial that showed improvement in overall survival and progression-free survival. And you can see the curve on the right-hand side there, a nice difference there. There's also a trial presented at Astro a few years ago from China. Again, a phase 2 trial with an SIB boost in there to 54 gray with improved survival versus the 45 gray BID arm. I don't think these trials have really changed the standard of care yet, and I think people are waiting to see if a more robust phase 3 data become available at some point. But it's certainly interesting to have this out there. Go on to the next slide. So I think a lot of centers do use daily radiation instead of twice daily for small cell, and there's a good basis for that from the CONVERT trial. And you can see the initials there, how they got the name. And this was a phase 3 randomized trial of 45 gray BID versus 66 gray daily. It started with cycle 2. A lot of patients were randomized on this trial. And it was a non-inferiority trial, and they were felt to be statistically significant. You can see there is some separation in the curve with twice daily a little bit better, but that was non-significant. So I think this is definitely justifies using 66 gray in a daily fractionation. The toxicity was similar except for the neutropenia. Next slide, please. So we put together. Chuck Simone was the first author on this, the Astro Clinical Practice Guidelines a few years ago. Unfortunately, it came out on March 13th, 2020, about 5 minutes before the world went to hell. So you might have missed it because you were a bit distracted with something else going on at that time. But we did, this was a consensus panel to develop recommendations. And one of the key questions were how to treat limited stage small cell. So we felt that twice daily radiation to 45 gray was a strong recommendation with high quality of evidence, and that daily fractionation to about 66 gray was conditional with moderate evidence. So we did feel that 45 gray was still the standard of care. Go to the next slide, please. So how'd this patient do? So she had a really nice response. You can see here 1 month post-treatment. So now I think a big question is, what do you do about the brain? So if you remember, she was 71 years old. So, big question is, does she get prophylactic cranial radiation, or do we just do observation? If we do PCI, what technique would we use? So if we go to the next slide, so this is again the guidelines, and this was the third key question. So for patients less than 70 years of age with good performance status, we did recommend PCI strongly with a high quality of evidence here. For patients who are a little bit older, so our patient does fit into that. You can consider, you should discuss it with the patient, see what other comorbidities they have. Shared decision-making, I think, is good no matter what the situation, of course. And if the patient is to get prophylactic cranial radiation, 25 gray and 10 fractions is the dose. So next slide for this patient, we did do 25 gray and 10 fractions. And I used a hippocampal avoidance here, so you can see the fields on this. and I do not typically use memantine in my patients. We go to the next slide. So this patient was actually somewhat interesting and shows you the twists and turns that can sometimes happen in small cell lung cancer. So you saw she had an excellent response, and 6 months later, there was a uptake in the left lower lobe. And so we did a biopsy of it. And actually, the pathology or the cytology came back. It was definitely cancer, but they couldn't tell if it was small cell or non-small cell. So one thing to remember, especially when you're treating small cell lung cancer, is that there can be a non-small cell component to the disease. So again, that might be a little bit of an argument against 45 gray, not your typical dose for non-small cell lung cancer. So this certainly could have been a persistent non-small cell component of her disease. So a question you might have is if this comes up in clinic, how would you treat this? We typically don't think of oligometastatic disease in small cell because of its high propensity to spread, but this is technically an oligomet. But since it's such a chemotherapy sensitive disease, would you just go with chemotherapy or what would you do? So if you go to the next slide, you can see we actually recommended 50 gray in 5 fractions. And the medical oncologist, felt like if we could avoid chemotherapy in her for as long as possible, it'd be good. And this was her only site of disease. So I just did an oligomet retreatment to that area. I think it was far enough away from the heart and the chest wall that we weren't too worried about the toxicity of it. I'm not going to talk about this patient any further, but just with the nature of small cell, if you go back up, she actually ended up developing brain mets despite the PCI. So in retrospect, I'm very glad we gave the PCI because we would have felt that we could have potentially, we know that we treated her to the maximum. And just of interest, the areas of brain mets were not near the hippocampus. So it wasn't a local failure due to the decreased dose there. But it just shows you the very aggressive nature of small cell despite her initial excellent response. So if we go to the next slide, here you can see just the evolution of therapeutics in small cells. So the shaded boxes are in limited stage disease. The yellow boxes are in extensive stage disease. So there's a time in the 90s to 2000, there's a decade there where when we give talks about small cell, we say all the advances are taking place in radiation, because chemo, once cisotopicide was established, carbotopicide just changes the toxicity profile. But the advances at that time were the addition of thoracic radiation, and there were some meta-analyses about that. BID, which we just talked about, Teresi's paper, prophylactic cranial radiation, which was a meta-analysis as well. But then, since that time, there has been definitely some advantages in the use of and some other therapeutics. So if we can go to the next slide, this is the hot topic for this year, the Adriatic trial. I was on a call yesterday, and someone who specializes in prostate cancer had heard of it. So that there's a high penetrance when a prostate cancer expert has heard of this trial. So very similar to Pacific trial, this is durvalumab. It has all these nautically themed names here. So durvalumab after concurrent chemo RT in a limited stage small cell. And you can see the curves there, big reduced risk of death, a big improvement in median survival. This is not the end of this trial. There's a third arm that's not yet been reported, durva plus trimi. So we'll see if that shows any advantage or what the toxicity profile of doing two treatments is for that. And before we go to the next slide, and so, I think the general thinking in small cell is and I think you saw it for this patient, and I think it's been the guiding principle, for medical oncologists the past few decades, even with superb, excellent response, a complete response, there is still minimal residual disease in small cell. And, extra therapy is definitely going to be helpful. And there's just been decades of failed therapies for small cell lung cancer, vaccine trials, other biologics. So this trial in Adriatic is really, very exciting to see, because it just, finally there's a therapeutic that's helping these patients who we know are doomed to have a recurrence sometime in the future in the vast majority of them. And this is something that we might get some advantage on. If we go to the next slide, there's also the NRG LU005 closed to American accrual in 2022 and Japanese accrual in December 2023. And this was giving atezo up front with the concurrent chemo-RT. So now that this trial is closed, we will be awaiting results from that. And I think thematically, this is somewhat similar to the studies in stage 3 lung cancer. And Aria discussed the Pacific trial very nicely with the adjuvant consolidated durvalumab, and LU005 is like Pacific 2, moving the immunotherapy up to the first line treatment. So hopefully we'll hear from this trial soon, and maybe some updates on Adriatic soon as well. I think that's my last slide. So if you have any questions.
Thank you so much. That was also a really great review on small cell lung cancer, and thanks for putting in the comments on PCI and things like that in there too. If there are any questions from the audience, again, feel free to type them into the chat.
Would it be okay if I ask one of my esteemed colleagues a question in this scenario as well? Because I'm learning a lot as well as sort of.
Only if it's for Aria. Aria.
Well, I have a question for Aria, and then I have a question for you. So it depends if there's other questions that go along with that too. But Aria, I was actually curious. I know, for your case, you went to 60 gray and 30 fractions. I was curious, is that I know some people are doing 66 gray at 30 gray at 2.2 gray per fraction with SI.
Yeah.
I'd love to hear from both of you that if you're locally advanced, are you dose escalating at all in any way, shape, or form from either you or Ken? I'd love to hear your thoughts about that.
Yeah, I mean, I have on occasion. I'm a little bit more of the purist with the data, and I'm like, well, 74 didn't work, and compared to 60, I'll stick with 60. But at times, if I felt I could meet constraints, I've gone up to 66. Actually, what kind of confuses me, and I have this, constant debate in my head as well. With small cell, we're going to 66 gray, and then for non-small cell, I'm stopping at 60. So does that make any sense? And it doesn't to me. So.
So actually my answer is pretty much the same. And I feel with the Pacific trial being so positive, and I feel like going to 66 gray, and don't forget, I used to go up to 84 gray, so 74 gray doesn't, I haven't done that in a long time, obviously, but 74 gray doesn't scare me, but with but if they caused toxicity that prevented the patient from getting consolidated durvalumab, I think that'd be a very upsetting toxicity to see. So I really don't do that unless it's a particularly fit patient with really favorable dosimetry, and then I'll try to tweak the dose a little higher.
Thank you for answering that. And then, good question. There's a question in the chat from the audience. Do you always do hippocampal sparing with PCI? And I was actually hoping to add a question of my own. Do you ever omit PCI for small cell and just monitor and do SRS?
just to be completely honest, though, another faculty member here does most of the small cell now. If I was seeing a small cell, I do try to get approval for hippocampal avoidance, though I'm usually denied by the insurance company. So my record's pretty spotty on that. And no, I do not recommend surveillance routinely. I feel we have a randomized trial that shows an advantage, or at least a good meta-analysis. Obviously, if there's some very specific reasons not to, I would hold off. But for the general patient, yes.
Okay, thank
My
you.
colleagues, what would you do?
I tend to offer PCI for my limited stage small cell, and I tend to do them all hippocampal avoidance. I've had better luck than Ken with the insurance companies so far, it sounds like, and in general, I've done PCI with memantine. That's how I've with hippocampal avoidance, and that's how I've approached it.
Yeah, it would be the same. I mean, I offer it. I'll be honest, I hate whole brain, but I think, until we have the Maverick data out, I think, PCI is still standard, so I'll offer it. But I also offer observation with MRIs every 3 months. And I haven't had issues too much, but we don't have a big small cell population here in Southern California. But the few I've had, I have been able to do hippocampal spares.
Thank you. And we're a little over time, but there's one last question. Let's try to squeeze it in and then wrap up. Do you cover only the PET positive nodes, or do you cover elective nodes also? If anyone can answer that.
I mean, I was trying to type in even for both, but I generally cover the nodes that are positive on PET or EBUS or mediastinoscopy if they have it. But on occasion, I had a case where it's, a right lung and a 4R. Would I cover the hilar node even though it's, not positive? I sometimes will include that in my volume, and that's technically elective. I've done that before.
Yeah, I definitely would include the hilum in that scenario. And also to remember, if you're treating the lower paratracheal areas or the hilum, you're getting a pretty high dose to the subcarinal area too. So it's really tough to avoid the subcarina. And so it's really becomes superior and inferior issue. So I won't chase a higher lymph node. So if it's 4R, I won't chase level 2. If it's level 2, I don't chase the supraclav area. But in the contralateral and midline position, you're pretty much going to cover it with what would be an elective nodal dose anyway.
Awesome. Well, thank you so much. Again, a huge thank you to Dr. Rosenburg, Dr. Amini, and Dr. Rosenzweig for putting in the time to make those slides, and really great presentations incorporating a lot of really recent data that has come out. This is just our contact information for the panelists, and you can always visit our website. This presentation is being recorded and will be uploaded to our YouTube channel as well as our website, radoncvirtual.com. And then also on our website, you can register for our upcoming session in October that's going to be on gynecologic malignancies. And similarly, we'll have 3 panelists presenting a few different cases. And that is all I have. Thank you so much.
Thank you again. This was great.
Thank you.
Thank you.
Bye.
Enjoy the shore.
Thank you. Have a good weekend, everyone.